Tanguy, we haven't talked about surgery too much. Kevin just brought it up. Tell us how surgery plays a role in the management of these patients.
Well, I think surgery is an essential part of treatment in general, and oftentimes patients come in through surgeons first. And I think for early stage surgery remains clearly the preferred option. Patients are done with treatment quickly, and it's highly, highly curable. But even especially for the HPV positive tumors, for more advanced tumors, oftentimes surgery is a consideration. There's now a new approach, it was briefly mentioned already, transoral robotic surgery or laser resections that may actually provide a good alternative outcome for early intermediate stage HPV positive tumors. We do some of that. I think the data is still emerging on when and how to best integrate it, but there are a number of trials actually to do that, and some centers actually do fair amounts of volumes with good results. It's also potentially a way to maybe de-escalate treatment. There's an ECOG study that I think is being led by Bob Ferris that explores the role of TORS in certain patients and gives them then less treatment otherwise, and I think it might play an important role. So I think the surgical techniques are evolving, the radiation techniques are evolving, but also clearly chemotherapy is evolving, and systemic agents and immunotherapy is just one of those areas that I think right now is really interesting as we're starting to see really positive data.
Viktor, how does the surgeon and surgical approaches come into play at your center?
Well, certainly novel techniques are also very important for the type of surgery, for the approach of surgery, and I think we have very dedicated surgeons as well in Germany, and they succeed on that path actually, and I think TORS is really an important tool for that part actually, to spare toxicity, to reduce the morbidity that we cause on patients with that type of approach. Laser resection would be another one, for in selected cases. So certainly this is not something you would apply to any patient at any stage. So these are really selected cases, and for those, there are novel tools on the horizon that play into the real world, and we will be more and more frequently using that in the future, I think.
Yeah, in fact, I dare say that many of the German surgeons were pioneers in this field. So we talked about the approach to the patient in general. We talked about surgery. We talked a little bit about systemic therapy. Kevin, as the token radiation oncologist on the panel,
yes.
Talk to us about radiation and what are the considerations in a patient with locally advanced disease.
So it's important to emphasize, I think, that the practice of radiotherapy has been completely revolutionized in the last 15 to 20 years. Indeed, when I embarked upon a career as a radiation oncologist, one of the questions I was frequently asked was, why are you bothering with this? It'll be obsolete by the time you're getting ready for retirement. and I think actually we've seen exactly the opposite. Radiotherapy is assuming an even greater role in the management of patients, and that's because we've got away from the old-fashioned techniques of large fields applied in a fairly indiscriminate carpet bombing fashion to both tumor and normal tissues alike. And actually the development of technologies such as intensity-modulated radiotherapy, the use of image-guided radiotherapy, where you use very detailed and accurate scanning techniques in order to define where the tumors are and where the normal tissues are, and you can deliver radiation to the tissue you need to treat and avoid the tissues you would wish not to treat. I think that has completely changed things, and I think standing out from my own practice is the work of my friend and colleague Chris Nutting, who performed the Passport study, which demonstrated that intensity-modulated radiotherapy makes a huge difference to the outcomes in terms of long-term dry mouth, which was one of the dominant effects of radiotherapy and one of the major impacts on quality of life. So I think we've gone beyond the old-style radiotherapy, and indeed the next generation of radiotherapy tools. I mentioned the phrase jokingly, arms race. Well, the surgeons have robotic tools in order to deliver surgical approaches. We've increasingly now got complex methodologies to deliver radiotherapy, including the development of things like CyberKnife and stereotactic irradiation, and also now the development of the MR-guided LINAC. And that really allows us to take images in real time of patients receiving radiotherapy. And the ultimate goal of that, of course, would be able to take functional images. So for instance, imagine a scenario where you could look at hypoxia on an MRI scan in real time during a fraction of radiotherapy and adjust the radiation dose to the hypoxic subfraction second to second during the radiation, or indeed to areas of high proliferation as measured, for instance, by diffusion-weighted MR during the fraction of radiotherapy. I think it's going to completely change the game. And then, of course, the other big player in the field is the emergence of proton beam. Now, proton beam has such really beautiful and exquisite dosimetry in terms of how it delivers dose to tumor tissue and can spare normal tissue. Of course, it has financial constraints, and I come from a jurisdiction where we don't yet have any machines, but we have plans to have 2 in the near future. And I think the understanding of where proton beam plays the correct role in patients with head and neck cancer is an important consideration. And I think in the first instance, those younger patients with highly curable disease who will live decades with the potential toxicities of what we do, I can foresee clinical trial scenarios where we can validate the use of proton beam for those patients.
Yeah, without a doubt. I can tell you from my own personal experience, the rates of xerostomia and the severity of xerostomia since the introduction of IMRT are dramatically different. Of course, your colleague, Dr. Nutting, that you mentioned, actually demonstrated that in a prospective trial. But the severe xerostomia that we used to see a decade ago, I think I hardly see anymore in my clinic. I don't know if your experiences were similar.
Also, when it comes, so very similar experiences, also when it comes to like fibrosis in the neck, actually much better outcomes. The other thing that I really would like to caution is, as these radiation techniques get increasingly complicated, experience again plays a big role. And I think it is very easy to say, oh, it's IMRT, but IMRT is not the same as IMRT at a center that has a lot of experience. In fact, having that experience is really essential. So I think, again, a plug for larger centers do better with these more advanced technologies.
It's a real skill set to be a radiation oncologist.
In fact, I always say the radiation oncologists are almost like the surgeons. It is a skill. Everybody can give chemotherapy, obviously the right one, but radiation is a real skill. Yeah.